Good morning, everyone, and welcome. I'm delighted to be here today to talk about a very important topic. Today's presentation is titled Bulbar Dysfunction in ICU, and I'm excited to guide you through this subject. We'll explore what bulbar dysfunction is, how it affects patients in the ICU, and discuss some key considerations for management and care. So, let's get started and delve into this fascinating and critical area of intensive care medicine. Let's look at this case of a 64-year-old man in the ICU who's presenting with some concerning symptoms. He's showing signs like slurred speech, a nasal quality to his voice, choking when drinking liquids, and having difficulty managing his secretions. He's also experiencing recurrent drops in oxygen levels, which suggests some respiratory compromise. Now the question here is, which feature most strongly indicates bulbar dysfunction? Remember, bulbar symptoms relate to problems with the nerves that control muscles in the face, mouth, and throat. Out of the options listed, proximal limb weakness, hyperreflexia, dysphagia with nasal speech, reduced vital capacity, and autonomic instability. The one that really points us toward bulbar involvement is the difficulty with swallowing and speech, especially with the nasal quality. These are classic signs that the nerves controlling those muscles are affected. So, in essence, when you see symptoms like dysphagia, nasal speech, and difficulty handling secretions, think of bulbar dysfunction. This helps us differentiate it from other neuromuscular issues that might primarily affect limb strength or reflexes. It's a good reminder of how important a detailed clinical picture is in guiding us toward the correct diagnosis, especially in complex ICU patients like this. Let's take a closer look at the correct answer, which is C. In this case, we're dealing with bulbar dysfunction, which primarily affects the cranial nerves IX, X, and XII. These nerves are crucial because they control many functions related to swallowing and speech. When these nerves are impaired, it can lead to several issues such as dysphagia, which is difficulty swallowing, and dysarthria, which affects speech clarity. You might also notice nasal speech, where the voice sounds nasal due to improper closure of the palate during speech. Additionally, weakness in the cough reflex can increase the risk of aspiration, which is when food or liquids enter the airway, potentially leading to pneumonia. Understanding these effects helps us recognize why bulbar dysfunction can be so serious, and why prompt diagnosis and management are essential. This explanation ties into our overall theme of identifying neurological impairments and their impact on vital functions. When assessing a patient with suspected bulbar weakness, it's crucial to identify the most urgent intervention. In this case, we see signs like pooling of secretions, a wet voice, and repeated aspiration events. These are classic indicators that the patient's airway is at significant risk. The key priority here is airway protection and early intubation. Ensuring the airway remains clear and protected is essential to prevent respiratory failure or further aspiration pneumonia. While other options like speech therapy or starting antibiotics might be part of ongoing management, they are not immediate priorities in this acute setting. So, the most urgent ICU step is to secure the airway through protection and early intubation. This approach stabilizes the patient and provides a safe environment for further treatment and assessment. Remember, in cases like this, airway management takes precedence to prevent deterioration. The correct answer here is A now. Let's talk about why that's so important. Bulbar dysfunction is actually considered an airway emergency. When the nerves controlling the muscles involved in swallowing and speech are affected, it can lead to a loss of protective reflexes like coughing and swallowing. This is a critical point because it significantly increases the risk of aspiration, where food or liquids enter the airway instead of going down the esophagus. Aspiration, as many of you know, can quickly lead to respiratory failure if not managed promptly. That's why early airway protection is absolutely crucial in these cases. Recognizing bulbar dysfunction early allows us to intervene before the situation becomes life-threatening. So the key takeaway here is that in patients with bulbar symptoms, Maintaining a clear and protected airway is not just important, it's a priority to prevent rapid deterioration and ensure safe breathing. This ties into our overall theme of timely recognition and intervention in airway emergencies. Let's take a closer look at this question. We have a 58-year-old man presenting with acute bulbar weakness, ptosis, fatigable dysphagia, and importantly, normal reflexes. His limb strength is preserved. Now, these features are quite characteristic and guide us toward the most likely diagnosis. First, consider the key points. Bulbar weakness and ptosis suggest involvement of the muscles innervated by cranial nerves, particularly those controlling the muscles of speech, swallowing, and eyelid elevation. The fatigable nature of his dysphagia points to a pattern that worsens with activity, which is a crucial clue. Next, note that his reflexes are normal and limb strength is preserved. This helps us narrow down our options, eliminating conditions that typically involve limb weakness or abnormal reflexes. Now, looking at the options. Guillain-Barré syndrome often involves limb weakness and areflexia, so it's less likely here. Brainstem stroke could cause bulbar symptoms, but it usually presents with additional neurological signs and does not typically feature fatigable weakness. ALS tends to involve both upper and lower motor neurons, leading to progressive weakness, including limb involvement, which isn't described here. This leaves us with myasthenia gravis, specifically a bulbar crisis in this context. It's characterized by sudden or rapid onset of bulbar symptoms, fatigability, ptosis, and preserved limb strength early on. The presentation aligns most closely with this diagnosis. So, in summary, when you see a patient with acute bulbar symptoms, fatigable weakness, and preserved limb strength, myasthenia gravis becomes the most probable diagnosis. It's a reminder of how crucial detailed clinical features are in guiding us toward the correct diagnosis in neurology. The correct answer here is D now. Let's talk about why. Myasthenia gravis typically presents with bulbar symptoms, which involve muscles responsible for swallowing and speech. You might notice fatigue-related dysphagia, meaning difficulty swallowing that worsens with activity, and nasal speech due to weakness of the muscles involved in speech production. Importantly, despite these muscle issues, sensation and reflexes are usually preserved in these patients. This pattern helps differentiate myasthenia gravis from other neuromuscular conditions. Understanding these key features is essential for accurate diagnosis and management, fitting into our overall discussion of neuromuscular disorders. Let's take a closer look at this scenario. We have a patient with bulbar dysfunction who appears comfortable, but exhibits a weak cough and has trouble counting aloud. These signs suggest that while they might not be in immediate distress, there's an underlying risk of respiratory failure developing soon. Now the question is, which bedside test would best predict that impending respiratory failure? The options listed are arterial blood gas, forced vital capacity, oxygen saturation, chest X-ray, and peak expiratory flow rate. Among these, the most practical and predictive bedside test in this context is the peak expiratory flow rate. It's a quick, non-invasive measure of how forcefully the patient can exhale. A decrease here can be an early warning sign that their respiratory muscles are weakening further. While arterial blood gases and chest X-rays provide valuable information, they are less immediate and more invasive or resource-intensive. Oxygen saturation can be helpful, but may not show early deterioration if oxygen levels stay normal initially. So, in summary, monitoring the peak expiratory flow rate gives us a real-time, functional assessment of the patient's respiratory capacity, making it the best predictor for impending respiratory failure in this case. The correct answer here is B now. Let's break down why. When we're looking at respiratory muscle failure, a key indicator is the forced vital capacity, or FVC. If the FVC drops below 15 to 20 milliliters per kilogram of body weight, that's a strong sign that the respiratory muscles are failing. It's important to note that arterial blood gases, or ABGs, might still appear normal until the very late stages of failure. So, Relying solely on ABGs could be misleading early on. That's why FVC is so valuable. It serves as an early marker for respiratory muscle weakness. Understanding these measurements helps us catch issues sooner, which ties into the overall theme of early detection and intervention in respiratory failure. So, always pay close attention to FVC values as a crucial piece of the puzzle. Let's take a look at this scenario. We have an ICU patient with bulbar palsy who is alert but has some significant swallowing issues. They're aspirating thin fluids and coughing repeatedly during meals, which indicates a high risk of choking and respiratory complications. So, the key point here is understanding the safest approach to feeding in such a delicate situation. Option A suggests oral feeding with supervision, but given the patient's aspiration and coughing, this might not be the safest choice without further modifications. Option B recommends thickened fluids only, which can reduce aspiration risk, but may not be sufficient on their own if the patient continues to aspirate. Option C proposes keeping the patient NPO, which means nothing by mouth, and initiating enteral feeding after ensuring airway protection. This strategy effectively minimizes the risk of aspiration and provides nutritional support through a safer route. Option D suggests starting parenteral nutrition immediately, but that's usually reserved for cases where enteral feeding isn't possible or safe, and it doesn't address the aspiration issue directly. Lastly, Option E encourages coughing during meals, which could worsen the risk of aspiration and respiratory distress. So, considering all these points, the best choice here is Option C, keeping the patient NPO and initiating enteral feeding once the airway is protected. This approach balances safety and nutritional needs, aligning with the overall goal of preventing respiratory complications in patients with swallowing disorders. Let's take a closer look at the correct answer, which is C. Patients with bulbar dysfunction are at a high risk of aspiration. This means that their ability to protect their airway is compromised, making them more susceptible to food or liquids entering the lungs. Because of this, oral feeding is unsafe until a thorough airway protection and swallowing assessment has been completed. It's crucial to prioritize safety in these cases, ensuring that swallowing function is properly evaluated before resuming oral intake. This step helps prevent potential complications like aspiration pneumonia and aligns with our overall goal of providing safe and effective patient care. Let's take a moment to review the key points on this slide about bulbar dysfunction in the ICU. First, it's important to recognize that bulbar dysfunction can significantly impact a patient's ability to breathe, speak, and swallow, which are all crucial for their overall recovery and quality of life. This condition often results from neurological impairments affecting the cranial nerves or brainstem. In the ICU setting, identifying bulbar dysfunction early is vital because it influences decisions around airway management and nutritional support. For example, patients with significant bulbar weakness may require interventions like advanced airway support or enteral feeding to prevent complications. Another important aspect is understanding that bulbar dysfunction isn't just a standalone issue. It connects deeply with our overall goal of providing comprehensive, patient-centered care. Recognizing and managing it effectively can improve outcomes and reduce the risk of secondary complications like aspiration pneumonia. Finally, as we've discussed throughout this presentation, early detection and multidisciplinary approaches are key. Addressing bulbar issues promptly helps ensure better recovery trajectories and supports the overall management of neurological impairments in critically ill patients. Let's take a closer look at what happens when there's an impairment of cranial nerves IX, X, and XII. These nerves are crucial for many functions related to swallowing and speech. When they are affected, we often see issues like dysphagia, which is difficulty swallowing, and dysarthria, meaning trouble articulating words clearly. Additionally, nasal speech can occur, making the voice sound nasal or congested. We also need to consider the weakness of the cough reflex, which can increase the risk of aspiration, where food or liquids go into the airway instead of the stomach. This combination of issues is what we refer to as bulbar dysfunction, especially in critically ill patients in the ICU. Recognizing these signs is key because they directly impact patient safety, nutrition, and communication, highlighting the importance of early detection and management in these settings. Now, let's take a closer look at some common causes of ICU-related bulbar dysfunction. First, we have myasthenic crisis, which is a severe exacerbation of myasthenia gravis that can lead to significant bulbar weakness and respiratory failure. It's important to recognize this early because prompt treatment can be life-saving. Next, Guillain-Barré syndrome, particularly the bulbar variant, can cause rapid-onset weakness affecting the muscles responsible for swallowing and speech. This syndrome is often preceded by an infection and requires prompt immunotherapy. Brainstem stroke is another critical cause. Since the brainstem controls many vital functions, a stroke here can cause sudden bulbar symptoms along with other neurological deficits. Motor neuron disease, especially ALS or amyotrophic lateral sclerosis, leads to progressive degeneration of motor neurons, which gradually affects bulbar muscles, causing difficulty in speech, swallowing, and breathing over time. Then there's botulism, a toxin-mediated paralysis that can rapidly impair cranial nerve function, presenting with bulbar weakness that can be severe but potentially reversible with appropriate antitoxin and supportive care. Critical illness neuropathy is also a key factor. This is a diffuse nerve dysfunction that occurs in ICU patients, often as a complication of severe illness or sepsis, leading to weakness including bulbar muscles. Finally, bulbar dysfunction in the ICU can often be multifactorial, involving some of these conditions or complications, highlighting the importance of a thorough assessment to determine the exact cause and guide treatment. Understanding these causes helps us better manage our patients and tailor interventions to improve their outcomes in the ICU setting. Let's take a closer look at some key clinical features that can help us identify bulbar dysfunction, especially in critically ill patients. One of the most common signs is choking on liquids, which occurs because of difficulty coordinating swallowing. This can be quite alarming and should prompt us to evaluate further. Another important feature is a wet or gurgly voice. When the voice sounds congested or has a thick quality, it often indicates that secretions are not being cleared effectively, leading to pooling and aspiration risks. Speaking of secretions, poor secretion clearance is a hallmark sign. Patients may struggle to cough or clear their throat, increasing the chance of aspiration and respiratory complications. Recurrent aspiration events are also typical. If a patient keeps aspirating, it suggests impaired swallowing or airway protection, which is often linked to bulbar muscle weakness. Additionally, nasal speech, where the voice sounds overly nasal or hypernasal, can point toward dysfunction of the muscles involved in speech production, again implicating bulbar involvement. Finally, in the ICU setting, bulbar dysfunction can manifest as difficulty managing secretions and swallowing, which complicates patient care and recovery. Recognizing these features early is crucial because they help us differentiate bulbar issues from other neurological or respiratory problems, guiding us toward more targeted management strategies. Let's move on to the ICU assessment, which is a critical part of managing patients with bulbar dysfunction. First, airway protection is paramount. We need to ensure that the patient's airway is secure, especially since bulbar weakness can compromise their ability to swallow and cough effectively. This might mean early intubation or supportive measures to prevent aspiration. Next, the forced vital capacity, or FVC, is a key test in this setting. It helps us assess the degree of respiratory muscle weakness and guides our decisions on ventilatory support. A declining FVC can indicate worsening bulbar or respiratory function, so close monitoring is essential. We also rely on arterial blood gases, or ABGs, but typically these are more informative in late changes. They help us evaluate gas exchange and identify hypoventilation or hypercapnia, which can develop as respiratory muscles weaken. After the patient stabilizes, a swallow assessment becomes important. This is to evaluate their risk of aspiration and ensure safe swallowing before reintroducing oral intake. It's a crucial step in preventing pneumonia and other complications. Finally, when considering bulbar dysfunction in the ICU, remember that it can significantly impact multiple functions: speech, swallowing, airway protection, and requires a comprehensive, multidisciplinary approach to care. Recognizing these key assessments helps us tailor interventions and improve patient outcomes in this vulnerable population. Let's talk about some key management principles for patients with bulbar dysfunction in the ICU. First, early intubation is crucial if the airway is compromised. This helps prevent respiratory failure and ensures the patient maintains adequate oxygenation. Next, it's important to keep the patient NPO, nothing by mouth, until it's safe to prevent aspiration, which can be a real risk with bulbar weakness. Treating the underlying cause is always a priority, whether it's an infection, a neurological disorder, or another condition. Addressing the root issue can significantly improve outcomes. Also, I want to highlight that non-invasive ventilation, or NIV, should generally be avoided if there's bulbar weakness present. This is because NIV can sometimes increase the risk of aspiration or may not provide enough airway protection. Finally, early ICU monitoring is essential. Close observation allows us to respond quickly to any deterioration and provides the best environment for managing complex issues like bulbar dysfunction. These principles all tie back to ensuring safe, effective care for these vulnerable patients. Let's talk about some important pearls when assessing bulbar dysfunction in the ICU. First, bulbar symptoms, those affecting the brainstem areas controlling speech, swallowing, and airway, are actually airway emergencies. So, recognizing these signs early can be life-saving. Next, it's crucial to remember that a normal arterial blood gas does not rule out respiratory failure. Sometimes, patients can look stable on their ABG, but they're actually struggling, especially if bulbar weakness is involved. Speaking of which, myasthenia gravis often presents with bulbar weakness, so keep that in mind when evaluating patients with sudden or progressive difficulty swallowing or speaking. Also, be cautious with non-invasive ventilation, or NIV, because it can be unsafe in severe bulbar dysfunction. It may worsen airway compromise or lead to aspiration. That brings us to aspiration, a leading cause of deterioration in these patients. Swallowing difficulties can cause food or secretions to enter the airway, leading to pneumonia or further respiratory decline. So, in summary, recognizing bulbar dysfunction is critical, understanding its implications for airway management, and being vigilant about aspiration risks can significantly impact patient outcomes in the ICU. Thank you so much for your time and attention today. I really appreciate the opportunity to share these insights with you. Remember, the key points we've discussed highlight the importance of understanding the core concepts and applying them effectively. I hope this presentation has helped clarify how these ideas connect to the overall theme of our work and how they can make a real difference. If you have any questions or want to explore these topics further, please feel free to reach out. Thanks again for being such an engaged audience.